I have the same problem, I would say. My cancer was, I had thyroid cancer, and that was like 20 years ago, something like that. So I was already in vet school. I'm a veterinary pathologist. And so I consider myself being in the know as well. You know, I knew what kind of cancer that was. I could read publications, and yet still, like, somewhere deep, there's always this, oh, what if it's like this whatever percentage is that it's not gonna go so well. There's always this little fear. Doesn't really matter how much you know. And I think this contact with the doctor that can reassure you and can like look at you and just talk to you is so crucial to basically comforting patients in this difficult situation.
To your question about the patient journey, I think a lot of people underestimate just how anxiety-inducing a cancer diagnosis can be, and the wave of emotions and thoughts that come with it, right? Like, did I do this to myself? Like, was I eating the wrong thing, or, doing the wrong thing? Is it something that was just inherited and naturally was going to happen? But it does force you to think about your environment and what you're doing in your life, right? Which I think is the silver lining in all of this, is that it gives you a chance to reassess your life and also realizing your mortality, right? And how do you want to choose to continue living?
Welcome, my digital pathology trailblazers. Today, I'm joined by Victor Angel-Mosti, the founder and CEO of Omica.ai. Welcome, Victor. How are you today?
Hi, Alex. I'm doing well. Thank you for having me.
So, Omica is a community-driven biobank based in Mexico City that's on a mission to bring Hispanic Latino populations to the forefront of precision medicine research. Victor, we always start with you. Let's start with telling the listeners, the digital pathology trailblazers, a little bit about yourself and basically your background, and how did this lead you to founding Omica?
Of course. Well, I was born and raised in Mexico City. My father is a cardiologist and my mother is a bariatric nurse. So I always joke that I grew up in a hospital. I spent way too much time in one as a kid. And then I went to school for biomedical engineering and then design. So I find myself to be sort of at the intersection
Interesting
of
combination.
yeah, yeah. I love building things. I think that's the takeaway here, and especially things that have to do with biology and medicine, biomedical engineering, and then design. And have been in startups for the last 15 years or so, and a couple of medical devices, and ultimately back into biology through personal experiences around oncology or cancer.
Yeah, I wanna dive into your personal experiences around oncology
Okay.
because this kind of started you on the path of founding the company, right? And I know this from the personal conversation. So if you could basically share with us your experience with cancer and how that shaped, basically uh, made you create the company, that would be fantastic.
Yeah, and I think I have to preface this by saying that it wasn't an immediate sort of action reaction. It actually took some time for things to naturally occur. But yeah, in a nutshell, I had a malignant tumor a few years back, and there was a moment where I was living between New York City and Mexico City. So my tumor was actually analyzed by pathologists originally in Mexico who couldn't figure out what it was. And then ultimately the tumor sample traveled to the United States, to a number of hospitals, eventually making its way to Harvard Medical School, where a very specific expert on that very specific type of tumor was finally able to identify it a number of weeks later. So in that, or throughout that journey, I not only was able to live through or see firsthand the disparities between even one of the top hospitals in Latin America versus, the average hospital in the United States in terms of their workflows and the way that they process data and the questions they ask around sequencing, et cetera. But more so the emotional side of this sort of journey that patients have to go through. I was very lucky in the sense that my experience wasn't so dire, and fortunately everything is okay. But I got a glimpse into what that experience can be for a lot of people and their families. and it's something that definitely informs and drives everything that we do at Omica today.
Hmm. So I want you to like tell me what the disparities were. Like what is the most, and you being a person who like knows both worlds, right? It's not
Mhm.
that, and like you said, you grew up in the hospital, so you know the healthcare system. You studied biomedical engineering, so like you're kind of in the know, and you still experience this journey. So here I want to hear what the disparities are, and I also if you're fine with it, because I know it's like a sensitive question, like how did you feel as a patient? And I'm going to tell you a little bit about my cancer experience that was like almost 20 years ago. But yeah, tell me what you felt, and obviously it, like you said, it was not action reaction, but what from these experiences made you later think, okay, yeah, I want to do something different in my company?
Okay, well, yeah, a lot to unpack, but
I
I
know.
think at first glance, the disparities, there is a very basic digitization gap
Hmm.
in the way that information is collected and the way that information flows between clinicians. Whereas in Latin America, there's a lot of inherent silos from the lack of digitization that calls for slides and blocks to be shipped all over the place at risk of, sometimes damaging or losing that sample. None of the clinical data was actually digitized. So it becomes there's a lot of gaps in the process
Hmm.
that made the entire experience very, very slow. Everything from permits, as to how to export these biosamples properly, etc., were things that were not really delineated in any sort of coherent process. It was something that we had to figure out,
Hmm.
and with the help of people at the hospital, etc., we were able to do so. But once you get to the United States side, we saw that everything was much more streamlined, and
Hmm.
digital pathology was not as big back then. It's still nascent in many places in the United States, but at
I
least there
mean,
is a
it still
culture
is,
around.
but people know what that is at least, right?
Yeah, and at least the information is flowing, doctors are connected, everything is living on a digital platform. But then on the other side, when you go to an oncologist in the United States, something that I realized was that this person wouldn't even look at me because he was on Epic, right? So he was asking questions,
Ah,
and he was
okay.
just sort of like typing away, sort of like in a very robotic, sort of unempathetic way or empathic way.
Hmm.
Not to blame him. I mean, that's how they need to practice, and that's what's required of them. And that was a very different experience from doctors in Mexico, where
Hmm.
culturally, medicine is still very much focused on bedside manner and focused
Hmm.
on the human side of medicine, which is something that does guide our vision as to if we develop digital tools for clinicians, how do you do them in a way that enables them to be more human and less of a data entry role, which is
Hmm.
essentially what
Yeah.
Epic requires these days.
Very much. And it's so funny. It's just, across the border, right? You have Mexico, and you have what you just told me is okay, you did have a contact, you did have like real contact with your doctor. You had a relationship with them, which is like what the whole US medicine is, I don't want to say complaining about, but noticing that this has been missing. On the other hand, on the other side, you have like digitization, you have the tools. So I assume you had everything written with pen on paper, and you had to scan it, right?
Mhm.
Or
Yeah,
however,
pretty
right?
much.
What about, so you have like the two ends that optimally would meet to provide the best possible care. Did you, so was there any option to digitize your slides, or did you have to ship everything?
We
um
had to ship everything, and I've actually been
mhm.
on a quest to find that slide. So I'm not sure where those slides and those blocks are. I think they're lost in
Uh-huh.
some biorepository in one of the hospitals where it jumped around. So yeah, it's funny. It's ironic that I
Mhm.
that I
Yeah,
collect
so
blocks on
I'm
a daily
gonna,
basis, but I don't know where mine is.
I know, for a
Sure.
living, right? And I have the same problem, I would say. My cancer was, I had thyroid cancer, and that was like 20 years ago, something like that. So I was already in vet school. I'm a veterinary pathologist. And so I consider myself being in the know as well. You know, I knew how, like, what kind of cancer that was. I could read publications, and yet still, like, somewhere deep, there's always this, oh, what if it's like this whatever percentage is that it's not gonna go so well. There's always this little fear. Doesn't really matter how much you know. um and I think this contact with the doctor that can reassure you and can, like, look at you and just talk to you, is so crucial to basically comforting patients in this difficult situation. And I'm also on the quest to find my blog. I don't know where it is.
We should join forces.
Right.
Back to your question about the patient journey, I think a lot of people underestimate just how anxiety inducing a cancer diagnosis
Hmm.
can be. And the wave of emotions and thoughts that come with it, right? Like, did I do this to myself? Right? Was I eating the wrong thing, or, doing the wrong thing? Is it something that was just inherited and naturally was going to happen? But it does force you to think about your environment and what you're doing in your life, right? Which I think is the silver lining in all of this, is that it gives you a chance to reassess your life and also realizing your mortality, right? And how do you want to
Hmm.
choose to continue living.
Hmm. I love it. It's like, yeah, the quest for meaning is there, and especially if something hits you
Yeah.
like that. When I was doing research for this interview, Victor, I did listen to a few of your presentations, and one analogy that you gave, was that in one of your conference talks, you started with a photo you took at a coffee shop, and that had beans from all over the world. It was Mexico, Guatemala, Peru, and you made this connection between coffee diversity and biomedical data. Can you walk the digital pathology trailblazers through this
Yeah.
analogy? Because I loved it. It was like spot on.
Thank you. Yeah, I think it was a few years back, and it was in London, and I was supposed to give a talk on diversity for genomic data sets. And I was
Mhm.
walking around London the day before the conference, sort of like thinking about what I was going to talk about, etc. And I walk into this coffee shop, and it just has a wall, right, full of beans. Like, there would be like maybe 30 something different types. And I start reading the descriptions, and they're like, oh, this one comes from a cloud forest in Guatemala above whatever altitude. And these incredibly remote places from all over the world somehow managing to get their beans into a London coffee shop. And I just found it to be so ironic that, you know, coffee shops have this amazing diversity, yet our genomic data sets are still grossly predominantly white European.
Mhm.
So I just found it to be a little bit absurd. You know, that we have supply chains to get beans from so far away, almost on a daily basis, yet we cannot seem to have enough biomedical samples to drive equitable research.
Mhm. So before we dive into like what the reality is and what the disparities are, if you would to tell us like the mission of Omica and what you do at Omica, in like a sentence, what would that be? Because I want to frame everything in the context of why are you doing what you're doing and how you're doing it at Omica.
The way we say it is we are unlocking the path towards precision medicine in Latin America. And we do
Hmm.
so by bringing Hispanic Latino populations and Latin American populations to the forefront of biomedical research and development. And for us, everything starts with the data, right? You need to have data from the different populations around the world in order to inform all the new diagnostics, therapeutics, AI models that are being developed, in order for these solutions to be able to be deployed back into the world in an equitable way.
Hmm. So, if we wanted to put some numbers to this problem, when we talk about representation in genomic studies, what does that actually look like for Hispanic and Latino populations? How are they represented or not represented?
Last I checked, and this is based
Hmm.
on like major biobank data, the Hispanic Latino representation in genome-wide association studies, which are a good proxy for genomic studies, is less than 1%. Some people peg it closer to 0.25%, so a quarter of a percent.
Okay, 1/4.
Yeah, which if you really do the math in terms of how many humans have had their genetic data analyzed or their genome sequenced, it's a very, very tiny percentage of the human population. So Latinos are even like a even smaller percentage. So when you start to think about, targeted therapies or any sort of personalized intervention, there is, you realize that there's a very, very stark gap between what is available today and what could be available if we really analyze these unique populations.
So Hispanic Latino also does not mean like everybody from Latin America, right? But we're talking at the country level or even at the like indigenous people's level, right?
Yeah, I mean, that's where it gets really interesting. And, I'm not a geneticist, but yeah, I've had some very enlightening conversations with people who have spent their lives mapping out genetic diversity, even with this very tiny sliver of data that is available. And the genetic diversity that you find all over the world is incredible, right? And even within specific regions, even within Mexico, from, one state to the other, there's the same, I would say the same volume of genetic diversity or between, China and the Americas exists between states within Mexico, right? Just from ethnic groups that have been separated for generations and generations and generations. Which, if you look at it through a lens of somebody who's doing target discovery, you realize that these are pools of unique genetic information that have never been seen and that could be the source of novel, drug targets and biomarkers for things that may, cure different types of cancer or different types of diseases.
And this is not the first conversation that I'm having on the podcast about the diversity of data necessary for actual personalized medicine. I'm going to link to this podcast in the show notes. I talked to Matt Levitt, who is the founder of the Digital Diagnostics Foundation, and they have a similar mission to do it in the US. And he's referring to indigenous populations and different places that are very underrepresented. But I think you are operating even at the totally different level. What do I mean here? I'm referring to the funding disparity, because you mentioned that in one of your talks that Mexico's National Genomics Institute has a yearly budget of 12 million compared to 800 million for its US counterpart. How do you even begin to tackle such a massive resource gap?
I mean, it's a bit of a cold start problem, right? Because like a chicken and egg, in the sense that you don't have data, so you don't have products based on that data, like diagnostics or targeted therapeutics, which means you don't have more data coming in. So you're sort of stuck in this in between where, there's no infrastructure, there's no funding, there's no private industry around it. And I think the way forward is really through what I'd like to call like citizen science, which is people who are passionate, starting to work at a local level to interface the local efforts with the global industries, honestly. So yeah, private, public, citizen science.
And you said that, okay, there is not really anything deployed in terms of digitization in Latin America, in contrast to the US, where the doctors are looking into the computer to type. How can this be leveraged to build something that's better what is causing trouble in the US?
The way we see it is we see the opportunity for a leapfrog, right? And this is something that's been seen in different industries in different countries, the way that mobile payments leapfrogged over credit cards in Africa. And there's a lot of examples like that around the world. I think precision medicine is one of these leapfrogs, or AI-enabled precision medicine is one of these leapfrogs that we could see in Latin America by virtue of there not being any legacy infrastructure. So we are in a wonderful position to really build the infrastructure from the ground up with the vision of what we want medicine to be, right? So learning, I think what's important is we need to learn from the shortcomings of, the last 15 years of medical infrastructure that were built in the US, learn from those shortcomings and design something that's better from the get-go. For us, that looks like integrated data, right? Data that involves from biosample to longitudinal clinical data with, patient participation sort of like baked in from the start.
So how would it use, like, give me a very concrete example. Like, if you were a patient again and you had this thing that you're trying to build on and you're working on, what would it be? Like, would you have it on your phone? Would it be, I don't know, what would it be?
I think it's a platform that connects both a patient portal, which can guide patients through the experience that they're living through, while also providing them the ability to participate in various research studies. I think people should have the liberty to research on their own and participate in science on their own volition. Simultaneously, this patient portal needs to be connected to some form of clinical decision support tool for clinicians that allows them to parse through the right type of data to make decisions on their own. I don't think we're at the place where, AI models can substitute the judgment calls that an oncologist need to make on a daily basis, but we can definitely ease their burden by sifting through the troves of data that are coming online to make sure that they're making the right decision for the right patient at the same time. And then simultaneously, these, patient and physician portals need to be linked into a population scale data assets that can be leveraged for real world evidence that can provide, all sorts of label expansion and the discovery of treatments that may be either unique treatments for the pharma industry or things like drug repurposing, which could provide, cheaper access to very effective therapies for places that are resource constrained.
So do you have already anything in place? How does it look logistically?
In terms of this infrastructure,
Mm-hmm.
yeah, so we ironically started from top down, where we started with aggregating a lot of the data that's already out there. So that means crunching a lot of analog data, a lot of paper, a lot of Excel spreadsheets, Word documents. We basically run them through our pipelines to harmonize the data, ontologize it, and create these population scale data assets that have longitudinal data linked to biosamples. And now from there, we're able to choose for different strategies of what type of omics data we want to obtain, right? Is it just the pathology image from the H&E, which are becoming more powerful than ever and very low cost, which is attractive to regions like LATAM? Or do we want to go into, genomics, RNA, transcriptomics, spatial, proteomics, et cetera, et cetera?
Mm-hmm.
And I think that's
So
where it gets really exciting.
do you have a direction? Like, what is more doable in Latin America?
I think for us, it's balancing the excitement of these new technologies and what could be, with all this data, and really grounding it in what could be accessible to the place that we're operating out of. And that is why we are particularly excited about digital pathology, because it has a lot of leverage, right? The input is very low for the amount of impact that you can have. Especially now with all the wonderful, AI models that are coming in from all over the world. It's something where for fractional cost of a genome, you can now improve the odds of a patient having a successful outcome, or, spending 5 more years with their family, simply by implementing these very, very simple solutions.
Mm-hmm. And what we're referring to here is the molecular predictions from H&E images, right? This is like, let's call it the one application of AI, because I know you leverage AI for workflows, and now with the large language models, I don't know how you guys were thinking about digitizing all this written data without the text recognition and
Oh
large
my God,
language models. Oh my
it took us
goodness.
a long time.
And now
So
miracle happens, like a miracle happens that
yeah.
you can now leverage paper at scale, right? But also this like other application of AI that you're saying, okay, we have these images, we can scan them, it has a cost associated with it, but it's the cost is a fraction of the cost that would be um, associated with actually doing these molecular analysis, which often is prohibitive, meaning they don't happen. And here, okay, do we want a prediction that can guide us in a certain direction, or do we want nothing? I would want to have a prediction from whatever is available, right? In a situation where I don't have an alternative, because the discussion here in the US and in like well-resourced countries is okay, but if it's not like 100% accurate, if it's not, if it's just like this prediction that guides you in a certain direction instead of like a specific indication of what mutation that is, right? And here you can use it how I see it. Okay, you could use it for as a triage tool. Use and later do the molecular tests on samples that have been already indicated by AI. Yes, here you should test for this and that mutation. And there have been a few publications about that. But in a place where this is not an option, then the second best thing for providing care would be just use the information from the prediction, right? What are your thoughts on that? Because I mean, resources, and okay, there is no money for this to do it in Latin America. It cannot be the only justification if it's not the right thing to do.
Yeah, and you know, I think as they say, innovation happens between a rock and a hard place. You know, in the sense that sometimes resource constraints are really what drive really transformational innovations, and that's an ethos that we've tried to embody in Omica, which is we're in Latin America. It's a drastically different health ecosystem. You know, comparing ourselves to the U.S. ecosystem and what companies are doing in the U.S. is a mistake, simply because it's not our reality, right? And I think that there's many different, you know, there's a design, also a design saying or framework that's most advanced yet acceptable, right? The Maya principle. And it's what is the most advanced thing you can do that it will still be adopted and implemented in the real world. And that's a check that we constantly have to remind ourselves before getting too excited about new technologies is how do you deploy them, and how do you deploy them at scale in a way that that makes sense to clinicians at the end of the day. And yeah, I mean, I think digital pathology has a huge opportunity in research constrained settings, particularly.
hmm I want to ask about something slightly different because, um, and you have this unique experience of like having lived in both places, and I have lived in Poland and I'm living now in the US. And historically, in plenty of places, you would have people coming from one place, going to another place, trying to deploy things that are not deployable. I know it's a sensitive topic because it has all this colonialistic heritage that people feel very strongly about, but we still kind of, I don't know if we do it. I hope we don't do it. How do you avoid doing it? Like coming with something that's not gonna be deployable somewhere else, even though it may be such a great technology. And it's more like a conceptual discussion. Like, what are your feelings and thoughts about that? Do you catch yourself sometimes? Like, do you have to catch yourself, like, not going in a way that you would go if you had all the resources, or just whatever you feel about that? Because it's, I don't know, it's like happening. There are disparities in the world, and people from the places that have resources want to help the places that don't have resources, but without ever having experienced the reality where they are trying to help, and sometimes it causes harm. I don't know. I hope I'm I'm clear enough with
Yeah,
this one.
yeah, I think harm and lost resources, and you see that too in the you know, startup VC ecosystem. There's so much waste of resources flying under the flag of innovation, when in reality it's a bunch of crap being created that never sees the light of day, simply because I think we don't listen enough, you know, as creators, as innovators, as designers, as engineers. Like the fundamental path to creating anything is starts by listening. Listening to your user, listening to your customer, listening to what people actually need. Um, and sure, maybe people don't know what they need because they're not familiar with the new technologies that are, the new possibilities.
Hmm.
But that's I think the role of a good designer engineer is to translate what's technically possible with what's humanly realistically uh, necessary. Um, and that's where every good design process begins, right? Sitting down with your end user and really asking yourself, how do I make this person's lives better?
Hmm. I love it. I know it from the software side a little bit. Uh, where yeah, if you just don't sit together, I mean, you're making something for the end user, right? If you don't listen to them, then what's the point of creating this thing? um I want to switch, well, I don't know if we're switching gears. I want to transition into the community aspect of this process. You mentioned this at the beginning, that okay, you would need to have like local enthusiasts, people who believe in whatever the innovation is, right? In this case, this biomedical innovation at the local level, to be able to disseminate it and to gain trust for this. And that kind of contrasts with something you mentioned as well in one of your talks, the parachute science. I was not familiar with this term, but basically, this is researchers coming in, extracting data, leaving communities with nothing. So, can you paint a picture of what this looks like in practice and why it's so problematic?
Sure. I'm going to try not to get in trouble, but um,
You can
yeah,
be
parachute
on the
science
edge, because
usually,
be as on the
without
edge as
naming
you
any
can
names,
be. No, let's, but let's describe
um,
what harm it causes, because it kind of ties into what we just said. Okay, somebody comes, wants to do good, and then leaves. In this particular context of parachute science, what does that mean for the people that are being researched? Let's call it like that.
yeah, and I think that's the issue, right? It's people being researched
Mm-hmm.
rather than
Mm-hmm.
being co-participants in
Mm-hmm.
research.
Mm-hmm.
And you see that in when people speak of biases, right? And they speak like,
Mm-hmm.
oh, the data is biased. And not only is the data biased, but the questions are biased because the researchers are often not representative of all the populations, right?
Mm-hmm.
If all your researchers are from, are English people from Oxford University, the questions that you're going to ask are may or may not be representative of the Mexico City population, so to
Mm-hmm.
speak, right? Simply because our needs and our interests, so to speak, or our priorities are different. And I think that parachute science is not, I don't think it comes from malice. I think it comes from simply the lack of a model, lack of examples of how to do community-based participatory research properly. And it goes back to my previous answer, which is it starts by listening. It starts by
Mm-hmm.
showing up and meeting communities and figuring out what the priorities are, rather than seeing them as test subjects or a source for something that you want to extract. And this has happened before in throughout Latin America, where it's happened with bioacids, with natural resources of plants that have specific compounds or enable people to create certain materials, etc. That used to be taken and exported and exploited internationally without ever giving anything back, right? So that's where the term biopiracy comes through.
Mm-hmm.
And I think now, as biomedical data becomes more of a centerpiece to research, we need to be very wary of not committing these same acts of biopiracy. And one of the ways to avoid that is precisely by, involving the community. And the community is not only the patients, it's also the clinician, the local researchers, people who have an incentive and an interest in actually solving a problem for that community rather than just extracting information
Mm-hmm.
um, for external use, so to speak. Yeah.
So, how do you do it? Like, let's say you would want to start a project in a new place. Who would you go to? Who would go? Would that be you? Would that be like? How does something like that start even?
So we base a lot of our work on the Nagoya Protocol. The Nagoya
Mm-hmm.
Protocol was created for biopiracy of natural resources, and it's a wonderful framework that I don't know if it's the UN or somebody, the FAO, but it's a way for scientists to interact with communities around the world to do research projects. But there's a key piece in those research projects, which is a fair and equitable benefit sharing agreement,
Mm-hmm.
which means if I exploit your natural resources or find something in your natural resources, I am committing X percentage back to you or something like that. And this
Okay.
is a pretty cool framework that hasn't been really applied in human research. I know there's a company called Variant Bio that has pioneered a lot of this work. And they're doing great. And I think it's one example of something that could really become prevalent
Mm-hmm.
in the sense that you now incentivize the physicians and the clinicians and the patients to participate in research, but they need to get something back, right? For us, that's the deployment of AI models back into the system, right? So when we use that data to train a digital pathology model, that hospital center or network of hospitals receives the AI model back in a free of use type of agreement.
So basically, it's a kind of a contract, right? That has to be a
Yeah,
kind of a win-win situation. We come in with something, and if there is a benefit we can obtain, then you will get a counter benefit because we're using your resources. Interesting. So I love the example you gave. Okay, we train on your data, but then you can actually use it to help your patients. Do you have any examples that you can share, like specific models that are already published or anything um like specific that you guys are working on right now?
so not yet. We can't share it publicly yet, but we are working
Okay.
on distributing two models. They have to do with cancer recurrence. So they predict
Hmm.
the possibility of a patient experiencing recurrence, which informs the use of adjuvant chemotherapy. So we believe that these will have a tremendous impact in Mexican health systems, not only in terms of improving the patient journey and outcomes, but also in terms of costs that health systems can save in unnecessary chemotherapies, basically.
Amazing. Most people compartmentalize work and personal values, but when your company is literally addressing medical inequalities, how does that show up in your daily life? Like, do you have to keep yourself in check, or can you like switch it off? Do you act differently there and here? I know I do when I go to Poland. Um, because there I'm in my Polish reality and people don't necessarily know everything, how things work here. And when I'm here, I'm in the US reality. So, it's not at the business level, but basically personal. Um, and I think that's, I don't know if you can call it lifestyle, but that's some kind of skill that immigrants who did not commit to just one country develop, because that's
Yeah.
something we have in common. You work there and you work here, and by there I mean Mexico and here US. I also like go to Poland on a regular basis and maintain my relationships there. um how do you function in such a situation, personally and business wise, and what are the things to keep in mind, or how do you feel about it, or maybe it
Mm,
doesn't matter?
it does matter.
Mm-hmm.
It's what I'm trying, and I don't know if I've
Mm-hmm.
achieved this, but what I'm trying is
Uh-huh.
to make the best of both worlds.
Mm-hmm.
And some days it's the worst of both worlds, and you really feel that pressure, and you feel like you don't fit in anywhere, and you sort of feel misunderstood in either place. And I think there's other days where things click, and you're able to really, really see the value and the connection between both worlds, and acting as
Mm-hmm.
a translator between spaces. Um, a lot of times this becomes, especially with work, it becomes sort of glimpses of each place, right? Like what is each, in health systems in particular,
Mm-hmm.
what is right about this health system and what is right about
Mm-hmm.
this one and what is wrong, and trying to, a mental exercise is trying to to figure out how to borrow from each to create a whole new reality, right? And I think this is very, very valuable. Um, but back to your original question, I think that being in Mexico and walking through the hallways of a lot of these health systems is super necessary to remember why, why we're doing this, why we put up with, bureaucracy, and why, we wake up every day to keep chiseling away, because the need is there and it's a very human need. And to me, that's like pure creative oxygen, so to speak.
Hmm. I think a big differentiator of these type of initiatives that actually have a potential to change something is the understanding of both realities. You have um always there are these like discussions going on. Oh, this country is better because of something, the other country is better because of something. US is the sixth country I lived in, and very quickly, I think after the third one, I realized that there's no perfect country. There are things working in one place that are not working in the other place. And also, it's not that you can like swap the non-working things from one place for the working things in another place. So every time there's like a discussion, oh, we should introduce this because another country has this and they live so nicely. And an example of that is going to be, okay, maternity leave, right? um in Poland you will get a year, in Canada you can get a year, here you cannot get a year. And like, I don't know a mother that would not like to have a year with their kids. And yet, like, just implanting that this in the US would not work. And the same for healthcare, the same for, all the other things that seem so obvious to be wrong somewhere else. But then the magnitude of implementing and all the interconnectedness of this little thing that you would want to swap, um, can only be understood if you actually live there, if you use this healthcare system, if you somehow understand it. So yeah, kudos for wanting to work on it, because it's freaking difficult.
It's very difficult. It's very difficult, yeah. And back to listening, I think sitting down with the patient, sitting down with the clinician, I think something that I've learned is not think about the whole system. I think change
Hmm.
happens at an individual level,
Hmm.
and if it's a good change, it'll spread, right? So it's counterintuitive, right? People always tell you to think bigger, and how is this huge? And at the end of the day, you just have to make a tiny little change that's actually a change.
Let me tell you why I love it. Because so I was to do my PhD, I had a scholarship. It was a scholarship for people from different countries to go and study and do something in Germany. And the deal was, you we give you the scholarship if you go back to your country and like implement the stuff. You don't have to pay it back. If you don't go back to your country, you do have to pay it back. So obviously I'm not where I started, right? So I had to pay my scholarship back. But I remember people who were our mentors in this scholarship, and I talked to one of them, and I asked, why did you choose to do it? Because And he said, well, in the worst case, I am giving one person a fantastic experience for 3 years and fantastic learning experience in a different country. In the best case, they will actually go back and implement it. So either way, I am helping someone. And this is what I'm hearing in what you're saying. Yeah, like, you help one person is like the smallest scale that you can operate on. But there is the potential to grow it organically from that one person. I love it.
But it's hard. It's hard.
I
Yeah,
know,
to make
because
that, for me at least, yeah.
yeah, and especially, you're a designer, you are an engineer, like thinking in terms of leverage, and now also like in the terms of AI, thinking in terms of leverage of impacting more than just one person at a time is how you want to do these things. So then if you only like do one little thing, you get discouraged. But don't get discouraged. I cheer for you. But I want
Thank
to
you.
ask you,
Yeah.
speaking of
Mm,
technology,
good.
you guys are using blockchain for data transparency. We didn't talk about data transparency. We kind of touched on the sensitive topics, like indigenous population, like the parachute science, but um, you started talking about this being a consensual process that somebody is giving their data, and you are using blockchain for that. For somebody who's not familiar with this type of blockchain use, can you explain why this matters and how it changes the way this consent is obtained?
Yeah. So we have used blockchain in the past. Right now, we
Mm-hmm.
don't need to use it.
Okay.
I think it's a very good application for blockchain. Why? Because
Mm-hmm.
blockchain is immutable, traceable, and you have a contract that is transparent,
Mm-hmm.
which is one of the missing pieces in a lot of uh, biomedical research studies. And back to parachute science, there's been instances where, big pharmaceutical companies come into a country and they somehow get their hands on, a ton of biosamples, and those biosamples lead to a drug target, and nobody knew where those biosamples came from, or if the patients had consented, to
Mm-hmm.
participate in research or anything like that. And some people argue that, that it's a net positive and that research should be done. I think the future is a place where people participate in research, right? And I think as patients, if we know where our information and how our information is being used, I think it's a powerful narrative, and it's a powerful action for people to come together to accelerate research. We saw that too with 23andMe, right? When they went bankrupt,
Mm-hmm.
people didn't know where the data was going to go, who was going to buy it. So I think the world is changing in that regard. And right now there is an opportunity for the creation of these participatory science platforms, and even some that can redistribute profits back to the
Mm-hmm.
participants, right? Or benefits.
So basically, traceability and like the transparency would be um, the biggest advantage of blockchain in this, and then you know where it comes from and where it should go to in case, um, not only like in case of benefits, but also like, okay, if you need follow up, if you need like any additional data that you would want to have, you can
Yeah,
basically
exactly.
go and ask for it. And chances are, if somebody already was invested in this being done, they will want to give the follow-up information, so not only like
Yeah.
on the side that, oh, nobody really knows, but here you know exactly and you can ask them, and why should they say no if they already said yes?
Yeah, and it's I think it's a big gap
Mm-hmm.
in biobanking infrastructure. You have a lot of biobanks that were not designed for today's type of research, right? That were designed
Mm-hmm.
for a different era where biosamples were basically perishable and you used them once and then you incinerated them. Nowadays, you need to future-proof your biosample collections, right? You need to make
Mm-hmm.
sure that consents are dynamic, because you don't know what technology is going to come out tomorrow. And, if your consent didn't have, spatial transcriptomics 10 years ago,
Exactly.
you need to be able to reconsent patients. And I think the only way to do that is to do that through participatory research, of keeping
Mm-hmm.
patients involved in the future of science.
So how does your biobank look like? What are you going to be working on this week, and basically what's your daily or weekly routine in Omica as a business, and how is it run differently than the
Our
biobanks that you
weekly
just monthly or whatever, right? How is it run differently than the biobanks that you just described that may not be future proof?
So I think our routine and the way we operate is starts by being embedded within existing hospital systems. So we
Mm-hmm.
don't see ourselves as as a biobank that's just picking up things from
Mm-hmm.
all over the place, but rather as a partner, as a clinic, as a partner to the hospitals,
Mm-hmm.
in the way that we are able to digitize all of their information and organize their biorepositories and ultimately sequence their biorepositories. So we partner with hospitals to provide them with a future-proof data asset that they can then leverage for research partnerships. So I think that's the main difference. Is that we are embedded within their workflow. So we do get access to constant patient flow. We are able to consent and reconsent and even recruit patients, which is the only way that we found that we would be able to implement these sort of dynamic consents and participatory research and the like, versus other biobanks which operate sort of statically and retrospectively. This is like a living biobank. Yeah.
Because you have the contracts with institutions and you're embedded in them. So what's your biggest fear about the future of precision medicine if we don't solve the diversity problem that you're working on?
I think sort of like getting to this uncanny valley, right? Where maybe people perceive that, and a lot of people are saying this, and I don't necessarily agree, but you know how people are saying, no, you should no longer study medicine because AI is going to take over, you know, the medical practice. And I think that's the wrong narrative. But in a worst case scenario, I do see a world where AI models are sufficiently good to be able to be implemented at scale and deployed at scale, but sufficiently bad to not be able to translate worldwide, right? So my biggest fear would be to have a shortage of physicians in lieu or supported by suboptimal AI models, which lead to worse outcomes.
Yeah.
That's a bad situation.
That's bad. Anything that you believed 5 years ago that you now think was completely wrong?
I think it's back to that scale thing, you know, like always thinking how things can be bigger. And I think right now I'm more focused on how to work smaller and more focused. So think small rather than think big.
Okay. And if you could go back and give advice to yourself when you first started, what would you say? Other than think small instead of think big. Anything else that you would like advise yourself?
Think be patient. I think I underestimated how difficult health systems would be.
I think health systems,
And how long
business
things
as
take. Yeah.
well. It takes a long time.
Yeah.
I know. That brings me to another thing. Like, then, obviously everything in life is hard. Pick your heart. But then you need to believe in something enough to pursue, because there's so many like easier things to do that you could do that are lucrative and can help people as well. And you as a designer, you could have picked something else. Um, for people who are listening to this, for the digital pathology trailblazers, whether they're researchers, clinicians, or just people who care about health equity, what can they do to help? Specifically, you and Omica, and in general, like what can they do to help the situation?
I think both to help the situation and if they want to help Omica out, I think is if you know of research studies that would benefit from data diversity or diverse participants, to reach out, and reach out to us and reach out to all the other, research groups in the region who honestly, we have a lot of underfunded scientists and they're brilliant minds that are working with very, very little resources who would be delighted to work with international research groups. And that would really, really propel forward the mission of Omica and the mission of Latin America as a participant in scientific research.
So what kind of participants are you looking for? Like, is there...
Us particularly? Right now we're very, very much focused in breast and cervical cancer. So that's an area that we would be ready to collaborate on. But in general, oncology is our focus.
Okay. Any specific one thing that you'd like people to remember from our conversation today?
To think small. To think small and
I'm gonna take that one. Take that one.
Think small. Definitely. And keep it personal,
Keeping it personal. Yeah, personal, relatable. And then I guess, I don't know. I think always that, okay, if it's a good thing, it's gonna be amplified. Even if you're
exactly
gonna do it at the smallest scale possible. Thank you so much for joining me today. And thank you
Thank
so
you,
much
Alex.
for doing what you do. And actually, I hope that maybe one day we can do a vlog story from going to one of the hospitals that
Mexico
Omica
City.
Omica is.
That'd be fun.
Yeah, I'd love to go. I visited Latin America a few times. I was in Mexico like 2 or 3 times. I visited Bolivia. I would love to dig deeper and see how things
Oh yeah, let's
look.
do it.
Okay,
That'd be
let's
fun.
plan it.
Okay.
Thank you so
Thank you so
much. You
much,
have a
Alex.
wonderful rest of your day.
Take care. Bye bye.